I specialise in women's health. I run a number of clinics, one in St John's Wood, which is a gynaecology practice, one in Kensington, Tunbridge Wells, and also in Ireland as well. And run a team of nutritionists who work with me, and we help women with, yes, polycystic ovary syndrome, couples who have issues around fertility, but also problems like endometriosis, fibroids, young girls with irregular or painful periods, women who come off the pill and then the periods don't come back, which is actually quite common, women going through the menopause who are looking for a natural way of approaching this stage in their life, and also prevention of osteoporosis. So it's really trying to help women through any stage in their life cycle where they may have hormonal issues. So we're going to be looking at polycystic ovary syndrome tonight, and then the fertility issues that woman may encounter, and try and cover as much as possible in the time we've got together. But do stop me as we go along. If something is not clear, I will also stay around afterwards, and I'm happy to answer either professional questions but also personal ones if you've got them as well. So do use the time, I'm happy to do that. So polycystic ovary syndrome, it affects 5 to 10% of women of reproductive age across the world, and unfortunately it's the single most common hormonal imbalance of women of that age. So it is actually a huge problem for women, and it's the major cause of infertility, and I'll show you why that's the case, and also one of the major causes of miscarriage as well. Unfortunately, it's frequently misdiagnosed and often missed completely. And we'll look at the hormone profiles that women will be suggested to do from their GP and what's going on with those hormones. So it is a syndrome, which means that there can be a group of symptoms that are associated with PCOS. It does mean, though, that this is a continuum. So there can be women with very subtle symptoms or very extreme, and they will all have PCOS. It just depends on how severe they have the problem. So one of the biggest ones that you would see would be weight gain, especially around the middle of the body. So we're going to be looking at that in terms of why the weight is going on there. And they will also have male symptoms as well. So acne, oily skin, and also hirsutism. So they will get excess hair. It could be facial, it could be in the inside of the thighs, it can be around the nipples. So there will be a lot of excess hair generally. And unfortunately, that sort of male dominance of hormones can also cause scalp hair to thin, or they lose it. So they're getting certain sort of a male pattern baldness going on the scalp, but then it's excess hair, acne on the rest of the body as well. No or very few periods, and this subfertility. And this is one of the major issues, and I'll show you what's going on there. Higher risk of miscarriage. So with these women with PCOS for fertility, it's not only helping them to get pregnant, we also have to help them stay pregnant. And they have two of those issues going on at the same time. And that's why just having fertility treatment, they still have the risk of miscarriage. So for them, it is getting them pregnant and helping them stay pregnant. And then there's these others which are connected with insulin resistance. Now this also relates to fat around the middle, which I've also written a book on, which applies both to men and women. But these clues, like the skin tags, the accordans, which are those floppy bits of skin which are often seen around the neck area, could be under the armpits, that would indicate that there is a problem with blood glucose going on. And the same with this discoloration. It could be between the elbow and the shoulder. There can even be changes in pigmentation around the neck. So the skin looks dirty, but it actually isn't. And then we've got mood swings going on, and also loss of libido. So we have this collection of symptoms which make it a syndrome, and there will be variations in how many symptoms a woman gets and how extreme the symptoms are. Now, the Rotterdam criteria is the criteria that is mostly accepted in terms of the diagnosis of PCOS. And it's been put together by the European Society of Human Reproduction and Endocrinology, and also the American Polycystic Ovary Society as well. It's called the Rotterdam criteria because that's where they all got together in order to make the decision about what this criteria is. But there are others, but I have to say, doing the research for the Natural Solutions to PCOS book, and I have put an appendix in the back which lists the other criteria, but this is the one that is mostly accepted. And what they're saying is that for a woman to have a diagnosis of PCOS, she must have 2 out of these 3, meaning infrequent or no ovulation, signs, so either physical appearance of hirsutism or acne, or higher blood levels of male hormones, and polycystic ovaries as seen on an ultrasound scan. Now this changes the way PCOS has been diagnosed in the past, because there was always a differentiation between a woman having PCOS, polycystic ovary syndrome, and a woman having just polycystic ovaries and not having any blood tests that mirrored it. So what this has done is expanded the diagnosis to many more women, which in a way I think is helpful, because it means others can be included in this who may have been left out before. So I've actually put up here the 4 different categories. This is all in the book as well, but it shows you that there are variations on this theme, because before it was assumed if a woman is having a roughly regular cycle, she can't have PCOS. But they're now saying we could put her into that category. So we've got polycystic ovaries on an ultrasound, male hormone symptoms and infrequent periods. Or she could have polycystic ovaries, again seen on the ultrasound, male hormone symptoms but a normal menstrual cycle. Or she could have PCOS on the ultrasound, no male hormone symptoms, but irregular or no periods. Or the ovaries could appear normal on a scan, but she has male hormone symptoms and irregular or no periods. And that one, definitely the last one, has been more unusual, because before it was always what can be seen on an ultrasound scan and then doing tests afterwards. So what we're looking at here, and the wording is misleading, it should not really be called polycystic, because these are not cysts on the ovaries. It really should be polyfollicular ovary syndrome. These are follicles with immature eggs inside. So what you see is the normal ovary at the top, and then we've got this polycystic ovary at the bottom. And what it is basically multiple follicles, very small, immature follicles. The ovary looks like a bunch of grapes. It can be larger in size, but these are all follicles. They are not cysts, and no connection with ovarian cysts whatsoever. But we are sort of stuck with the name, and I think it does mislead some women. But it's really a polyfollicular ovary syndrome. So when we're looking at testing in terms of drilling this down, we're looking at them blood tests. So these women, normally in a woman without polycystic ovary syndrome, normally she has higher FSH, which is follicle stimulating hormone, and lower LH, luteinizing hormone. In a woman with PCOS, it's the opposite, and oftentimes the LH is twice as much as the FSH. So she's got high LH, low FSH, and she could have high or at least normal estrogen. And this is important, because any woman who is not having a cycle, so she's amenorrheic, oftentimes in the clinic we see women who go to their GP not having a cycle, and he sort of says, well, leave it for a while, more convenient not having a period, we'll just wait and see. And sometimes a year, 2 years goes by. But that diagnosis of why that woman has amenorrhea is critical, because she could be going through a premature menopause, which medically is called premature ovarian failure. It's POF. And there is a wonderful charity, if you ever see women who are going through an early menopause, it's called the Daisy Network, and I'm one of their patrons. And for them, their biggest risk is the risk of osteoporosis. They will have low estrogen levels. Now, this woman with PCOS does not have a risk of osteoporosis. She has no periods, the same as this other woman who's going through the premature menopause, but the hormone profile is completely different and her risks are completely different. And that's why it's important to always have a diagnosis for this woman who's amenorrheic. Why doesn't she have any periods? Because her risk factors change depending on that diagnosis. Now this case with a woman with PCOS, because she has high or normal levels of estrogen, she can have what's called endometrial hyperplasia, where the womb lining builds up over time because of this higher level of estrogen, and then that increases the risk of ovarian cancer. Sorry, womb cancer, endometrial cancer. So it is important to know what the level of the profile of the hormones are and that woman's risk factors, which differ depending on why she's got no periods. I'll talk about SHBG, but it's sex hormone binding globulin, and it's usually low, and she will have higher levels of androgens. And then looking at the ultrasound, there can be 10 or more follicles, but they're all small.
Do you mind moving this way because you're in shot? As much as you can. More.
Unless you'd like to be in the video, would you?
More.
Do you want me to stand further back? I could go.
A little bit more if you can. Just a little bit more.
It's going to get warm in here, you know. Right. 10 or more follicles measuring 2 to 9 millimetres in diameter. A healthy follicle, you'll see, is 20 millimetres. So these are very small follicles, so many follicles on the ovaries, very small, very immature, and increased ovarian volume, so the ovary can be larger as well. So they're looking at those different characteristics, and there can be obviously the outward male symptoms going along with this as well. Now, what's really interesting is when you drill down into the polycystic ovary syndrome research, one of the biggest factors is this weight loss. If a woman can lose even 10% of her weight, there's this remarkable change in ovarian function. In one study, 82% of the women who had previous and ovulatory cycles showed improvements, and you'll see in this other one, 11 out of 12 women who were overweight with an ovulatory cycles conceived naturally after reducing their weight. But for them, it's very difficult to lose weight because it's a metabolic problem. And when you see women with this condition, my suggestion is that although in a way we are focusing on helping them to lose this weight, we are not projecting that to that patient because they will have tried every diet under the sun and found it very difficult. But it is almost to put them at ease in terms of that why they're finding it difficult to lose weight is because this is a metabolic situation, there is a hormone imbalance, and to focus on that, because once we get the hormones in balance also will come the change in weight. So it's how we look at this and how we talk to the woman about this, but there is a remarkable change just by a small percentage weight loss. And you'll see this here, weight loss and ovarian physiology, 33 and ovulatory overweight women, 27 of them were oligoamenorrheic, meaning they would have some cycles but pretty irregular. Significant reduction in ovarian volume and the number of microfollicles per ovary. And among the 27 women with oligoamenorrhea, 18 resumed normal cycles, 15 having spontaneous ovulation, and 10 pregnancies. And this is only this small change, this drop in weight between 5 to 10%. Yeah.
Do you see a similar success in women who have PCOS but are not overweight? So see their actions.
I'll come on to that. It's a very good question about women with PCOS who are not overweight. And yes, you will do, but one has to be very careful because obviously some of them can be on the thinnish side and we don't want to drop the weight too much. But the underlying cause can be the same, but it doesn't manifest in a weight gain for them. So that's the answer there. Half of all women with PCOS are not overweight, but the common thread is actually they will all be insulin resistant, whether it comes with the weight gain or whether it doesn't. So the treatment that we're looking at in order to make them more insulin sensitive is regardless of the weight. But thin women with PCOS, higher insulin levels in their blood than those without PCOS. So we're looking at insulin resistance being the driver for a woman overweight and PCOS, and thin or normal weight and PCOS as well. So we have to help them overcome this insulin resistance. And this is the miscarriage side of it. Miscarriages are much more common because of this high LH level. And in a study of PCOS where women lost weight, look at the rate of miscarriage drop from 75% to 18%, a staggering drop in percentage. Now, it is about helping this woman get pregnant, but we have to address this high LH level, and that's in the hormone balance that we're trying to achieve. It is no good a woman with PCOS using the normal ovulation sticks to check for ovulation, because those sticks measure the LH surge that is there about 36 hours before that egg would be released from the follicle. But this woman with PCOS has high LH levels all the time. So it doesn't matter, even if she's having a sort of a regular cycle, she could be testing with those sticks and her level would be high all the time. So she cannot even check to see if she's ovulating because of that high LH level. So the only way we can do it is actually with ultrasound, where she can have a monitored cycle and then they can see under ultrasound whether she's ovulating or not. But it's this high LH which is the instigator of the higher risk of miscarriages associated with PCOS. So this blood glucose control is the key, and it's really important because in her case, insulin stimulates the ovaries to actually produce more testosterone. So it's this effect of insulin actually on the ovarian function that's giving her some degree of those male symptoms. Higher testosterone will give her hirsutism, the weight gain around the middle, and also acne. And insulin will cause her liver to produce less sex hormone binding globulin, which I will cover. And also we have to think of the adrenal glands as well, because she's going to produce androgens from those glands too. So what we're aiming to do is basically target every aspect of PCOS at the same time in order to make this treatment effective for her in a short space of time. Now what we're looking at here is the problem with insulin resistance, which you probably know very well, but here we're looking at normal insulin metabolism. There would be insulin receptors here on the site of the cell, and they are sensitive to insulin, so the amount of insulin that's produced is a good level and then moves that glucose out of the blood into the cell. In terms of insulin resistance here, we have the resistance with the receptors. High levels of insulin is produced in order to overcome or try and overcome that resistance, but they end up with low intracellular glucose, high levels of insulin, and also high levels of glucose as well. But the high levels of insulin for her, it's not only, yes, can be weight gain, but we're also then talking about this effect on her ovaries from this high levels of insulin, causing the ovaries to produce more testosterone, and will shift that whole hormone profile within the ovaries, which then causes the feedback mechanism to the pituitary, and then that produces an imbalance of FSH and LH. So she goes round in a vicious circle. Sex hormone binding globulin is important. It's a protein produced by the liver, and it's often one of the markers done on a blood test for a woman with PCOS. As the name implies, it binds excess hormones, or it binds hormones so that there's less to target tissue, and in her case, less to target hair follicles, skin problems. And it is important, it controls both estrogen and testosterone, so actually really beneficial for her generally, but it's also beneficial if you think of other women with an estrogen dependent or an estrogen sensitive condition like fibroids, endometriosis, estrogen dependent breast cancers. They all need good levels of SHBG to control estrogen, but in this lady we need it to control both estrogen and testosterone. So it's important that her liver is producing enough of this, and it's often low in a woman with PCOS. And what we're looking at is this vicious circle, and we have to, in my opinion, break this circle in as many places as possible in order to target the problem. Now normally medically the choices would be either to put her on the pill, and it would be a pill like Dianette which has an anti-androgen in there, and she would be on that all the time, and could also be given metformin, which is an insulin sensitizer. Often she may be on both of those. Now what is interesting is in the clinic more and more women and the young girls are coming in and know that some of them will have been on, say, the Dianette and come off it. Some, that's what they're suggested to do at the moment. And they're thinking this in terms of their long-term health, because they've come to the realisation that if they do this, when they come off of it, they're in the same position as they were before. And they're thinking in terms of their long-term fertility, because normally they're told, well, you go on the Dianet until you want to get pregnant, and then we'll use ovulation stimulation in order to help you conceive. But they're just moving from one drug approach to another. And many of them are thinking, I want to sort this out now, so that I've treated the underlying cause, and then that's also thinking then about their long-term fertility, that they're then not going to need fertility treatment. And even if they have stimulation for ovulation, they have still got the risk of a miscarriage. So that's the issue. It may help them get pregnant, but because of that imbalance of hormones, they've still got a higher risk of miscarriage. So we're trying to really change what's going on. So they have this, if we start at the top, increase insulin, which decreases. Insulin itself will cause the liver to produce less sex hormone binding globulin. This, unfortunately, then increases testosterone, which gives them an ovulation, hirsutism, and of course then infertility. We're going round here to insulin resistance. They can have abdominal obesity, which increases the risk of metabolic disorders like type 2 diabetes. They've got weight gain there, and that in itself increases insulin because they've got insulin resistance. So more insulin is produced by the pancreas to try and overcome that, and they're stuck in that circle. So we are aiming to, in a way, attack this circle at every place that we have evidence from the literature that will make a difference, and do all of this at the same time for that woman, rather than just focusing on one aspect of this. Okay, so I'm going to cover the 7 most important dietary steps. Any questions so far that you'd like to ask? Yes?
Can I just check, if somebody's got high sex hormone binding globulin and also higher testosterone against estrogen, progesterone, what could that be?
Well, unless the testosterone and that is so high that there's not enough being bound. The other way to check that would be to do a saliva test. So those were done by bloods. But if you do a saliva test, you're looking at the free available hormones that are not bound to globulins, as they are mostly with blood, and then you'd see what is left really to target tissue like hair and skin. It would be a way of looking at that and seeing what's happening there. Yeah?
I don't know if you said it because I was a bit late, I got lost, so I'm sorry if you're repeating yourself. What would you, if you have PCOS but you want to use some form of contraception, is there a preferable one, and what do you think of the coil PCOS?
If a woman has PCOS and wants to use contraception, then what would be the preferred one? The difficulty with the pill, whether it's got Dianet in it or not, carries risk. It does. The one often used would be just a straightforward coil, but if a woman is having some periods, it can cause those periods to be heavier. It can. The other choice that is often given with women with heavy periods is the Mirena coil, which carries with it or releases progestogen, which is a synthetic progesterone, into the womb lining. So it basically stops the womb lining building up. So that is often given. I have to say that for some women, especially those who are using it for menorrhagia, which is heavy periods, for some women it's been miraculous, and they end up not having a period at all because the womb lining doesn't build up enough in order to be shed. But then there are other groups of women. It causes breakthrough bleeding for a little while, and that's supposed to stop as the body gets used to it. But for some women it doesn't stop, and they end up in a worse situation because they're bleeding on and off all the time, whereas before at least it was a set period of time every month. And the other biggest one is that if women who took the pill before got mood swings in the second half when the progestogen bit is added in, they now have it all month because they've got progestogen being released every day of the month. And some of them then have magnified PMT symptoms all the time. So again, it's what suits a woman and what she gets on with, and you can't predict how well a woman will get on, say, with the Mirena coil versus some other contraception. So the one we have to put as number one is the sugar and refined carbohydrates. I know it will be one you know well, and we're talking about putting her on a low GI diet. And we're talking about controlling not only the impact of high levels of glucose, but the response by the pancreas in producing or having to produce a lot of insulin all the time. Now, I have put on this roller coaster, and it is a really important one. It's one I talk about a lot every day in the clinic because it's the one that affects most women across the board, but you're seeing here the implication for PCOS, and it's the same implication for fat around the middle, any kind of central adiposity, both for men and women as well. And you're looking at here the effect of the blood glucose and then the output of insulin in order to match that. But the difficulty here is that this insulin level for that woman with PCOS is causing the ovaries to produce too much testosterone, but it also causes the release of the stress hormones, and then obviously is having extra pressure on the adrenal glands. She may also be stressed from outside, which we have to help control as well, but we have to think of the adrenal side and the production of male hormones from those glands as well. So we're thinking it ovaries and male hormones, adrenals and male hormones as well. And when we think of that central weight going on, the example is insulin is the fat storing hormone of the body, and we've got cortisol here actually putting that weight around the middle. So there will be this change in body shape, and sometimes they can be on the slim side but still have this excess central fat. So there will be variations on this. But it is helping this woman to control this, both from controlling her blood sugar but also cushioning the stress side of it, which I will cover as well. So we are thinking of removing any kind of added sugar from her diet, and in any form whatsoever. So there will be different forms in many cereals, or a classic example where they may break it down into 4 or 5 different sugars, because if it was just sugar it would be the first ingredient on the cereal packet. But we are aiming to move her away from these added sugars into the food that she's eating, and it's really important. I have put up here some examples because there is this misconception, and day in, day out we will see women in the clinic who say, I'm eating really healthily, I'm eating an organic live fruit yogurt. There can be 8 teaspoons of sugar in a fruit yogurt, but for her it's the organic, the low fat where her focus is on. And they've worked it out now that if somebody does not put sugar into their tea and coffee, they can be consuming 47 teaspoons of added sugar a day, because it's hidden in foods like this, which are more obvious, but also in the savoury ones, the mayonnaises, salad dressings, tomato ketchup, spaghetti sauces, 47 teaspoons of added sugar. So this is something that I think people are not aware of, and they're not even considering it. And I was asked a while back by the You magazine, the Mail on Sunday magazine, to write a piece on yogurt. And I did, explaining about, to look at the ingredients on it and to mention about the added sugar. And what it really stirred up a bit of a hornet's nest. The amount of emails that came back, it was like I was saying something really bad about yogurt, but people had this complete misconception about yogurt being a completely healthy food, but not even thinking about. And then if you look at the diet yogurts, you are looking at something with then artificial sweeteners, fructose, other things added in, but not added sucrose. But I think it's an eye-opener. People are not reading the labels. And just to show you, I know I'm talking to the converted, but it is important about this idea of low fat. This is what women have got into their minds that is the way to lose weight. If you look at the evidence, it is not. We're talking about low carbohydrate, low fat for weight loss, low carbohydrate, blood sugar levels more balanced, significantly more weight loss at 6 and 12 months, significantly higher HDL, the good cholesterol. So time and time again, it's this evidence. It's just that for most women, they focus on the low fat, no matter how much sugar or refined carbohydrates might be in that product. And somebody told me an example recently of somebody going to a slimming group, no names mentioned, and she went round to visit the lady, and apparently there are certain sponge fingers that you can buy which are 0% fat. And she ate the whole packet. And her friend said, "What are you doing?" She said, "Well, I can eat all of these because they're 0% fat." So it's that misconception. I mean, they were completely white flour and a lot of sugar, but there wasn't any fat in them. So, you know, it's trying to help with that education. I have put up here artificial sweeteners because that is normally the thinking then, well, if I'm not going to have the added sugar, I'm going to go for an artificial sweetener. And what the research is showing is that it actually increases that person's appetite and causes weight gain. They are extremely sweet. And normally when the body tastes that kind of concentrated sweetness, along comes a bulk of calories to go with that sweetness. But in the case of artificial sweeteners, those calories aren't there. So what it does is it sends that person off to get the calories from somewhere else. So it increases their appetite, and along with that comes the weight gain. Yeah.
Do you mean even what we might call healthy sweeteners, like xylitol or stevia blend?
No, not that. Xylitol, stevia, they're fine. We're talking about more the artificial ones, the chemical versions. They are also classed as neurotoxins. And I gave a talk at a cancer conference a while back, and a neurologist gave a talk, and her thinking around the artificial sweeteners was they do not cause brain tumours, but if somebody's got the hint of one, it will accelerate the growth. And you think of most of the chewing gums where you could have this artificial sweetener going up through the soft palate straight into the brain. So it is this understanding that these are not a substitute for sugar, and in fact are in a sense worse because they are completely artificial. And just this fairly recent research, only last year, people who drink 2 or more diet drinks a day, waist circumferences increases 500% greater than people who don't drink diet drinks. So these are very addictive, but it is this thinking that artificial sweeteners, no calories there, but there is this change in appetite, change in weight, and particularly this central weight with it. So it's helping people to come off this and get the understanding of why these drinks are not a substitution for sugar. Okay, we need to talk about the omega-3 fatty acids, and again the consumption of these has gone down by about 80% because of this low fat, no fat. I'm going to leave all fat out of it because all fat is bad, including nuts and seeds and oily fish. But the other shift that's taken place is this shift towards a dominance of omega-6 rather than omega-3, and you'll see from this research up to 25 times too much omega-6 to omega-3. So 2 things are happening: the lower consumption of omega-3, but the higher consumption of omega-6 coming in from a lot of the foods. So a lot more vegetable oils being used, and especially for women who may have been on things like evening primrose oil for years. So there is this shift, and we often test this ratio in the clinic, and recently a woman 55 times too much omega-6 to omega-3. And it is really important to get this right. When we look at it in terms of just the blood sugar side, we know that by getting these levels right, they actually make the body more, or the cells, more responsive to insulin. They are helping to overcome insulin sensitivity. And in this trial, all they did was substitute 7% of dietary fat with omega-3s for 4 weeks. So the other 93% of dietary fat stayed the same. So this was a small percentage shift. And in that 4 weeks, reversed insulin hypersecretion response to glucose. So it doesn't take long for the body to make these changes. And when you think of the fluidity, this is what we're aiming for with these omega-3s. Same as you would know in terms of brain cells, same as we know in terms of cardiovascular health. But this is happening on to the insulin receptors in order to keep them sensitive and fluid. I don't know. We could open the door if it's quiet now. Those back windows are open. I don't know whether that would change your lighting, will it, if we turn the light down? It would alter it now, wouldn't it? Do you want to try one of those lights off? There, I don't want to move because I'm wired up.
Can you do the other one? So that, no, the other one, the last one.
Last one.
Yeah.
Yeah? Yeah.
Does that mess you up or is it all right?
It's good for the camera.
I don't mind. I don't know whether it then saves the... And apparently now, in America, the women for the menopause, they're trying to make it more positive. Not having hot flushes, they're having power surges. So if you're having one in here now, it's going to be seen as a very positive sign. I have mixed in here some of the fertility ones as well, because I thought while I'm talking about omega-3s and while I mention a nutrient, then to include some of the fertility aspects. And with a woman with PCOS, okay, yes, we are working on her fertility and ability to stay pregnant, and at the same time we have to think of her partner as well. So just to show you, these omega-3s are important for her, but they're actually, oh sorry, that's the one on male hormones and PCOS. I'll come to the others in a minute. So this one is a woman with PCOS and the omega-3 fatty acids and the reduction in both acne and excess hair. So they are important not only in terms of that insulin sensitivity, but that is also going to change the impact of the message of insulin in terms of the ovarian function and the production of male hormones. This is the important pathways, which I'm sure you know well, but we're looking at here at the omega-6 fatty acids. You've got evening primrose here. And you've got this anti-inflammatory PGE1, which is fine. But the difficulty is if there's not enough omega-3, too much omega-6, the pathway will continue into this pro-inflammatory response. And that's the negativity of having too much omega-6 and not enough omega-3. Whereas when you look at the omega-3 fatty acids, the conversion down to EPA and DHA and then further down into these anti-inflammatory cytokines and prostaglandins, they are only ever anti-inflammatory. They can never veer off into a pro-inflammatory response. And this is really important, in fact, today for everybody's health. And we should be looking at this ratio between omega-3 and omega-6. And most of the research now on degenerative illnesses, if we put all of them together, cardiovascular disease, diabetes, Alzheimer's, and cancer, the research is looking at inflammation as being the cause. And if we can control inflammation, we can change the long-term effects or prevention of these degenerative illnesses. And that's why getting this ratio right is extremely important. And you will see many women who will have been on evening primrose oil, or a lot of them are taking 3 and 6 combinations, because their understanding is that it's the correct balance. But it always has to depend on that woman's starting point. And if she's already got too much omega-6, it's adding even more into what she's already got. So we have to be really careful. And my thinking now is if we don't test for it, we just have to put in the omega-3s and put those in, because most of the women are going to be skewed towards this omega-6 side.
Can you have too much omega-3?
Sorry?
Can you have too much omega-3?
You could have too much omega-3, yes, you could. I have to say, we've never seen it in any of the tests, but of course it would be possible. It would. The dilemma with the starting point here for flax, for vegetarians, and that lady was 55 times too much omega-6 was vegetarian. There is only about a 5 to 10% conversion down from flax to EPA and DHA. So if somebody doesn't mind, I'd do it as fish oil, omega-3 fish oil, rather than starting up at the flax and going down. Otherwise, they're going to have to do it with flaxseed if they are vegetarian, and just check the conversion.
Chia seeds, are they well absorbed?
Yeah, chia seeds, I don't know in terms of the conversion. I don't know whether a lot of research has been done on that. But again, the best way is to test and see. You'd know. And then you know which way you've got to work in terms of creating a balance. Yeah? Well, it's interesting because each lab comes back with different measurements. So one of them says it should be only 2 to 1. You saw that research before that was 1 to 1. But they give a 2 to 1, 2 to 1 omega-6, 1 omega-3. Some don't do it like that. So you have to go with the range that the lab gives you, and then go with how they measure it. Because some are measuring ALA, some are measuring EPA. It is a bit confusing.
How can you easily see if they're converting?
Sorry?
How can you easily see if they're converting flax to omega-3?
Because some of the labs will test every step on that pathway. Some will give just a ratio. And of course, everybody's paying privately for these tests. So sometimes, if cost is an issue, you just get the ratio. If there is a query about conversion, then there are tests which they pay a lot more for, but it shows each step of that pathway, and you can see where the conversion might be blocked.
Which are the best labs for that?
Oh, there's a few. There's the doctor's lab, there's Biolab, there's Genova, so there's a few of them do the whole screen. Sometimes we just do the ratio because you know there's a cost issue for the person. At least it's better to do that than not do it. Yeah?
For someone like the type where you've mentioned 55 to 1, would you do sort of megadoses for very short periods?
With a lady with 55 times too much, yes, much higher levels of flaxseed, or in her case, she decided that she was not happy to eat fish, but she would take fish oil capsules for a while because her biggest issue was pain. That's what she'd come in as the presenting symptom, a lot of joint pain, a lot of uncomfortability, and seeing that ratio flip the other way, she made the decision that she would take fish oil capsules for a while anyway, but still wouldn't eat fish. And that people may make those choices. Sorry? You can use algae oil, but if you look, obviously algae oil, the DHA will be a bit higher, but the levels of EPA and DHA are so low, they're very low. But it may be the way for somebody to do it with algae. It may be, and that may be, they just may have to take more of the capsules or more of the liquid. Okay, I put up here PCOS and inflammation just to show you why it is important to push this to this anti-inflammatory side. So women with PCOS can have high levels of inflammation. This is C-reactive protein. It's the marker of inflammation in the body. It's a really easy blood test. It won't give an indication where that inflammation is, but it's a key marker in terms of an inflammatory response going on in the body. Women with PCOS, 96% higher levels than they should be, even if they are not overweight. So we do think of overweight and obesity as actually an inflammatory disorder. It is, and fat cells will produce inflammatory substances, but you're seeing an increase in inflammation even when there isn't the weight gain there. So we have to get an anti-inflammatory effect for this woman with PCOS. Yes?
Sorry, I just wanted to ask about sort of the whole debate between salmon as a source of fish oils, and some people say that you have to go for the wild salmon versus the farm salmon, which we normally get in supermarkets because they have higher omega.
Are you talking about in terms of fish oil?
No, in terms of the actual fish.
Oh, in terms of the actual fish. Yeah, I personally would, if I'm eating salmon, I either buy wild or organic and would avoid the farmed except if I'm out and that's being served for dinner. But my choice would be wild or organic salmon. Yeah, rather than a farmed version. Okay, and I have put the men's one up here as well. So these omega-3s are important for her and him as well. And when you're talking about fertility and increased risk of miscarriage, yes, the woman with PCOS will have an increased risk of miscarriage, but we always have to factor the man in. I won't have time to go through with it, but in the Getting Pregnant Faster book, I have covered sperm DNA fragmentation, where even if the semen analysis looks good, there can be more subtle problems going on with the DNA, which would increase the risk of a miscarriage. So even though it's the woman that miscarried, if something is not 100% with the sperm, nature will always work on survival of the fittest. So we have to look at them both as a pair and work on improving sperm health as well as her hormone balance as well. And one of the issues that the scientists are coming up with is not, yes, there is a drop in sperm counts by up to about 50% over the last 10 years, but it's this increase in abnormal sperm that is more worrying, because either the woman might not get pregnant in the first place, or she may conceive and then that would be an increased risk of miscarriage. And often the sperm, either it's very obvious in terms of two heads or two tails, or they could have this DNA fragmentation, which can be measured, but it's much more subtle than a semen analysis. You wouldn't necessarily see it on that.
So motility, how important is that?
Motility is important because obviously if they don't get to the egg, then fertilisation is not going to happen. So you can improve it, and in fact for men we can improve all the parameters, including count, motility and morphology. So we've got, I say, in a way, many more tools to make changes. And the biggest impact for women is that oftentimes if there is an issue with the sperm, the woman is recommended to have an ICSI treatment where that sperm is physically injected into the egg. So it's a higher tech than IVF, and she will have to go through drug protocols even though she might not necessarily have a fertility problem. But when you look at the evidence, and I will only cover some of it today only because of limited time, when you look at the evidence in the literature on male factor fertility, it's enormous in terms of putting changes in there that can overcome low count, low motility, high levels of abnormal sperm, which may allow this couple not to even need ICSI treatment. So it's really important, I think, for couples to know that information is out there. And for a woman, although it's acknowledged that we cannot change ovarian reserve, and we can measure it with a blood test to look at whether her ovarian store is low, but we can change the quality. And that's the really important, I suppose, powerful thing for a woman to know, that she has been born with that set number of eggs and that can't be altered, but it's possible to change the quality of those eggs over a 3-month period of time. Okay, omega-3 fatty acids, just to show you again on the male side, 238 men with poor motility, reduced count and abnormal sperm randomised to EPA DHA or a placebo, significant increase in sperm count compared to placebo, and this increase in antioxidant activity. And you'll see the power as we go through, and there's much more in terms of what can be done on the male side as well as what we're doing to help the woman conceive as well. And I put up here about this cytokine ratio because it's all about helping a woman get pregnant and helping her stay pregnant. Now, what's come out over the last few years is the immunological side of fertility and miscarriage. It came out a lot through women with rheumatoid arthritis, which, as you know, is an autoimmune condition. And when they get pregnant, oftentimes the symptoms abate. They disappear sometimes or just get much less. When they give birth, the symptoms come back again. In order for a woman to stay pregnant, her immune system has to basically quieten down in order to accept foreign DNA, which is coming from her partner. So a lot of the theories around fertility and miscarriage is that some women have a very active immune system that does not allow this suppression to happen. So they look at this Th1, Th2 ratio. So the Th1 is this autoimmune response, higher activation of the immune system, and the Th2, the suppressive. And if the woman has a higher dominance of the Th1, it can increase the risk of her not getting pregnant in the first place or miscarrying. The treatment is anti-TNF alpha drugs. That's what they would normally give a woman in that situation. But just to show you that fish oil can inhibit TNF alpha by as much as 74%. So we have natural tools rather than drugs in order to help modulate the immune system for a woman who finds it difficult to get pregnant and also stay pregnant. And of course, the cytokine production decreases as that EPA increases. So really important to get the right ratio for this woman who may have been told actually it's an immunological factor that's stopping her getting pregnant. That's the one I formulated for NHP. So I formulated a number of supplements. It's not my company, but they are supplements that where the levels or the combinations weren't, I suppose, good enough or in the right combinations that I would want in the clinic. So I formulated some that are higher levels or different combinations. And that one, you're looking at EPA 770 milligrams, DHA 510 milligrams, and they're all from small fish like anchovies, sardines, so no large fish like tuna, all wild. And they're all in the phospholipid form, which is the natural form, which is often said in terms of krill. But if you look at krill, the levels of EPA and DHA are extremely low. So they'd have to take a lot of it in order to get that anti-inflammatory effect. It's in fish oil gelatin capsules, and the other difference is that in the clinic I use a lot of supplements from all the different supplement companies, and a lot of women are coming in and saying, I can't continue taking fish oil, I can taste it for the whole day, it just repeats. It's got a little bit of peppermint oil in there, so they just taste like they've had a peppermint tea, and it's been much easier for them to carry on taking it over time. Okay, dairy products. Now I would say to the woman with polycystic ovary syndrome, take them out for 3 months. I gave a talk at Cam Expo weekend before last, and a woman came up to me after and said, did you really mean eliminate them? I said, yes. You know, it was shock horror. They naturally contain insulin-like growth factor, which is similar in structure to insulin. It can stimulate the storage of glucose and can trigger increased production of testosterone. So it's worth them taking it out. There's not going to be a catastrophe with low calcium. And I have put a chart in the PCOS book where women can see that they actually do get a lot of calcium from other foods. It's just this thinking of dependency that it's got to come from the dairy side of it. We know that women with PCOS can have twice as much as this IGF-1 than other women without PCOS, and the ovaries of women with PCOS are more sensitive to this insulin-like growth factor, and it has the ability to cause cells to divide more. So when we're talking about ovaries which are multifollicular, we want to keep that ovarian size down, and we want to keep the size of the follicles down. So anything that might stimulate activity, we don't actually want in too high levels. Yeah?
Does goat's milk have high levels of the
It will do, yes. I don't know whether it has less. So the lady asked about goat's milk, whether it has high levels of IGF-1. I don't know in comparison to cows. I don't know whether there is a chart somewhere that might show these levels, but it would be naturally within the food, it would. And this was just something interesting. When I did the research for the PCOS book, it was something about milk that caught my attention because it has a low GI, but they did a trial where they added just 200 millilitres of milk to a low GI meal and caused an increase in insulin response of 300%. So it changed the low GI meal into a high one by adding just that small amount of milk in there. So when you've got a woman who could be sensitive to this insulin side of it, or actually is insulin resistant, then taking these out for a while I think would be important for her. And there's been research come out this week on dairy and sperm health for men. So it's a factor across the board in terms of fertility.
Is that the same sort of with yogurt as well?
It would be the same for all the dairy, only because it's a natural, I suppose it's in there at a higher level, because in terms of that animal needs to be up on its feet very quickly when it's born. It's sort of not lying on its back for 6 months or so like a human baby would. It's something that has to be activated and needs a high level of growth very quickly. And so it needs that high level naturally within that food. It's there in just because it's needed in terms of what that animal needs as soon as it's born, because it's standing up almost immediately. Yeah?
What about dairy that's predominantly fat, no lactose?
Sorry?
What about dairy products that are predominantly fat, like butter or double cream, and very low in lactose?
I don't think it's connected to the lactose side of it. I don't think it is. I think it's inherent in that product. Again, I don't know the comparison between butter, yogurt, milk, the different forms, and I don't know if there's a chart available out there. But I think for a woman with polycystic ovary syndrome, she ought to just take it out for 3 months. It's not going to do any harm to remove it. She could back it up with a calcium supplement if she's worried and needs the confidence of that, but it's worth removing it and seeing what happens. Yeah?
Does this include whey protein?
Would it include whey protein? I don't actually know. I don't know. But again, I think if you're going to do no dairy, when in doubt, you take it out. Yes. Yeah.
No, I just want to point out it's the leucine.
Sorry?
I think it's the amino acid leucine in dairy that causes the spike. That's what I've understood.
Sorry, I couldn't hear you.
I think it's the leucine in dairy, the amino acid leucine that causes the spike.
Causes the spike of that IGF-1?
Yeah.
Maybe, yes. That might be a good point.
That's why the butter and creams and so on.
Yeah. But it would be interesting to compare it to goats and sheep and see if there's been, and I think also then the commerciality of the production probably does increase the IGF-1 as well, depending on, you know, how the cattle are looked after and that. And I think the levels are higher in America because of hormones that may be added to the cattle which are not added over here. Yes, can you shout to me please?
Yeah, I was just wondering if it's the same with soya milk.
No, it's not the same with soya milk, and it wouldn't be the same with rice or oat milk. It would be, it's inherent in that as an animal product. It would not be the same, no. And they would be good substitutes for that period of time if they wanted to put in an equivalent milk product. You know, obviously not an animal milk product.
The rice milk's quite sugary.
Sorry?
And the rice milk quite sugary.
If the product itself, whether it's rice milk or soya milk, is actually, for me, if it's an organic one and there's no added sweetener, I would use it and I'd go. And probably the soya would be better because it's a bean rather than a grain, so you can have a higher level of protein. But I would have to have it that it's organic, so it's not genetically modified, and it's made from whole beans. There's no isolate in that product at all, so it's got to be really clean. Okay. Increased vegetables and pulses. This will also cause a higher, apart from all the other health benefits, will increase SHBG. So again, it's giving her the understanding of why she's increasing the fruit and vegetables. And I know the difficulty with nutrition is that we are giving advice and that person has to follow it. And it's very easy just to say, well, eat more fruit and veg, which is actually all of the messages outside as well, and still only about a third of people actually get their 5-a-day fruit and veg. So when we're talking about any condition, it's important to relate it to that particular, in my case I'm speaking to women, to that particular woman and why she needs to make that change. So if she understands that by increasing the fruit and vegetables, it is going to increase sex hormone binding globulin, and that in turn is going to then help control excess testosterone, she has got a bigger reason to include fruit and veg, which is personal to her, rather than the government recommendation you would need to eat 5 fruit and veg a day. So it's really important to target that advice as to why that woman has to see the reason that's big enough that she's doing this, rather than just a blanket message of, you know, more fruit and veg. Yeah. Yeah. Sorry, yeah.
I read a few years ago that broccoli is particularly good if you've got polycystic ovary.
Well, all the cruciferous vegetables would be good generally for this in terms of their binding effect on estrogen.
But I read a few months ago that it actually increases testosterone.
I don't know, maybe it's working by the SHBG side of it. It may have that effect on that, but most of the vegetables would do that anyway. Yeah, sorry, yeah.
If you were pregnant, would you recommend you to follow these steps as well? If you were pregnant and had polycystic ovary?
If you're pregnant, well, obviously you've overcome the fertility side of polycystic ovary syndrome. And no, I wouldn't do this when you're pregnant. I wouldn't suggest any woman diets. Everything should be done before pregnancy, because any kind of dramatic change in the diet, that detox effect is going to go into the baby. It has to be done before the pregnancy. And it is important with PCOS that it is done, because there is a higher risk of gestational diabetes in pregnancy with PCOS because of that, obviously, insulin resistance that's set up before she's pregnant. And of course there may be weight issues that she needs to reduce that weight before she gets pregnant. So, and in her long-term health, she has a higher risk of type 2 diabetes later on in life. So it is important that these steps are put into place as early as possible.
The natural colouring sugars in the fruit, would that not be a problem for someone who's insulin resistant?
The natural fructose in some of the fruits, it could be, but it's keeping it to a minimum and then looking at going to more fruits where that level is lower, such as apples and berries, and not having things like the dried fruits. If you think of this as a 3-month turnaround for polycystic ovary syndrome, which it is in fact for most of the conditions that I would look after, and for that time you'd be stricter and then could obviously gradually add them in. But oftentimes if they're eaten with a protein, it will lower that GI response of the fruit anyway. So nuts and raisins, if she is after something sweet and would have gone for a chocolate bar before, would be better to have that combination than it would be not to have it and then she's going off for the chocolate bar or the biscuit. And the pulses and the seeds. Pulses do stimulate sex hormone binding globulin, and also the lignans do in flax seeds. So they will increase it and will help decrease testosterone. So again, it's explaining why these are going in and the benefit generally for her in terms of that control and that balance of hormones. And cut out alcohol. As you know, there is a phase 1 and phase 2 effect going on in the liver, and of course she is metabolizing estrogen and testosterone through that liver function, and we're aiming to process that. Obviously it could become more toxic as it's going through this phase 1 and phase 2, and then we want it to be in this dilute inactive form as it's finished through that pathway. And it is important for her, again, 3 months, take the alcohol out, make these lifestyle changes and give herself the chance to actually create a healthy hormone balance. And again, we're trying to, I suppose we call it, attack it from every angle. We're not only talking about the balance from the ovaries themselves, but her ability to detoxify those hormones as well. In terms of conception, it is well known that women are suggested to avoid alcohol when trying to conceive. And the issue is that it can delay conception. And that's important, especially as many women are waiting longer now to conceive. When we talk about for women's age, we're talking about really 35, where fertility will take a bigger drop. But again, it's the quality of the eggs that we're trying to aim for. Even we see women 42, 43 in the clinic. The oldest woman we've helped conceive was up to 46, I think. So, and that's natural conception. But there is a delay in conception, and we are trying to help her get pregnant as quickly as possible. And obviously, with the issue around pregnancy, and it's the same with smoking, is that a woman is going to be 2 weeks pregnant before she knows she is. And so you've got a toxin going in there at one of the highest rates of cell division for the baby. So if she is planning a pregnancy, this should be out before she's even trying. And if we can get it out the 3 months beforehand, the quality of her eggs are going to be even better without that alcohol in there. And just to show you this, in another study, alcohol intake for women at any level significantly reduced fertility by up to 50%. And again, we have to think of it for the male partner as well. We're thinking both of them are going to be looking after themselves, getting themselves really healthy before conception, and doing as much as possible around that. And I put here caffeine as well. We are aiming to control the stimulant effect. They know that women with PCOS have increased levels of cortisol, and you're back to that roller coaster again, because the stimulant effect of caffeine will affect that roller coaster and will then obviously cause changes on the adrenal side, and there can be more of an output of male hormones coming, or androgens coming from the adrenals. And again, we're trying to target every aspect we can at the same time. So we know with caffeine and fertility, drinking as little as the equivalent of 1 cup of coffee a day, associated again with a delay in conception, sometimes up to a year or more. So again, a woman who may be in the older category, she does not want anything in there that's going to make it take longer for her to get pregnant. The difficulty is the caffeine will not affect every woman in the same way. We can't predict who's sensitive or not, so it's actually better to take it out completely. And obviously then, make other suggestions. Even decaffeinated coffee can increase the risk of miscarriage. I'll show you one on miscarriage coming up, but decaffeinated coffee can as well, because there are other stimulants left when the caffeine is removed. So theobromine, theophylline will be left, which would be in decaffeinated coffee but would not be in decaffeinated tea. So there will still be a stimulant effect of decaffeinated coffee. And for men as well, problems with sperm count, motility and abnormalities, dose related in terms of the caffeine intake. So it's one of those where we have to give lifestyle recommendations to both the man and the woman in terms of their fertility. And again, for her, there are issues about having caffeine during pregnancy. There are concerns around that. And only 2 cups of coffee a day, which is about 200 milligrams of caffeine, an increased risk of miscarriage compared to women who avoided all caffeine. And again, this woman with PCOS, she's already got an increased risk because of that imbalance of hormones. We have to then exclude other things that can be adding to that risk. It's just not worth it for her. So we're taking that out and obviously explaining why as well. So it's one of those issues where we need to explain why the caffeine needs to go. Trans fats, which you will be quite familiar with, but just to show you, 4 grams of trans fats a day can interfere with ovulation, giving a 74% increase in the risk of ovulatory infertility, which is actually what a woman with PCOS has got. The problem is that she's not ovulating, so she can't get pregnant. So again, these trans fats, they will cause and can cause hardening of cells, the same as they can increase the risk of cardiovascular disease, but that would be going on in terms of the insulin receptors. So we're talking about the effect of the insulin receptors and of course the health of the ovary as well, and keeping everything fluid and soft, and the communication then between cells as active and responsive as possible. Just to show you, this was a 2003 study. This was the benefits of using supplements. This was an analysis of 108 clinical trials using 36 herbs and 9 vitamins and mineral supplements on over 4,000 patients with diabetes or poor glucose control, showed an improvement in the control of blood sugar in more than 75% of cases. So we would use this same, and I'll show you the benefits that are useful for polycystic ovary syndrome and why they're useful. So anything that's going to overcome insulin resistance for this woman is really important. So the one you would always think of would be chromium. It's the most important one in terms of blood glucose control. It can help to reduce insulin resistance associated with PCOS. They've looked at that. That's from an article in the main fertility journal, Fertility and Sterility, and we know that people with type 2 diabetes have lower levels of chromium. So we're adding in key nutrients on top of a really good diet as the foundation, and putting some key nutrients in for around about a period of 3 months, and looking then at that change in symptoms. So whether it's a change in the cycle, it could be a change in some of the external symptoms that she's having. So there can be ways of measuring the changes. Magnesium, strong link between magnesium deficiency and insulin resistance, and we know that women with PCOS have significantly low levels of magnesium. And I have to say, in the clinic, calcium is not an issue with most women. They usually have plenty of that. It's always magnesium that is lower generally across the board. So we have to think about especially supplementing it in this situation for this woman with PCOS. Vitamin E, which you know is a powerful antioxidant, but it's also working in a similar way to the omega-3 fatty acids by keeping this responsiveness and this communication between the cells, by keeping the cells fluid. It's this fluidity of the cell membranes that allows the cells to stay or overcome insulin resistance, to become more insulin sensitive. And 600 IUs given daily to diabetic patients reduce both glucose levels and free radical formation in 2 weeks. So the body, like you saw, the other one was 4 weeks, the body responds quickly. But when we talk to this woman, I would always talk about the 3 months, because you cannot say really how fast she might respond. And if we put her 3 months there, then she's not disappointed after a month. Sometimes the changes start faster, and then it gives her the confidence to continue. But you're talking really, the biggest effect is going to be 3 months down the line. And vitamin C, even a slight deficiency can trigger high levels of cortisol. And what was interesting is from the Journal of the American College of Nutrition, that people who have good levels of vitamin C when they exercise burn 30% more fat. So anything that gives this woman an edge, who can often be overweight with polycystic ovary syndrome, it will help her then, when she's doing the exercise, that she's going to see more of an effect faster, along with what she's doing with her blood glucose control as well.
And what would be the daily amount to take?
Sorry?
What would be the daily amount to take?
I would normally give them 500 milligrams twice a day, split between 2 lots. And I would normally always use it in the alkaline version. It's not so critical in PCOS, but it is critical in things when you talk about osteoporosis, because we're trying to help that woman diet become more alkaline. And a lot of people in the clinic before said they couldn't continue taking vitamin C because it actually irritated the digestive side. So if you go for the alkaline version, magnesium ascorbate, then it's going to be much gentler anyway for every woman that you're talking to. It's a better version anyway. Sorry? Oh, sorry?
Milligrams, 500 milligrams.
500 milligrams twice a day.
What about the chromium?
Hmm?
How much is the chromium?
The chromium, I would give up to 100 micrograms. You can go 200 micrograms. I would never use, especially chromium, if they're on something like metformin. So the rider is, if they're already on an insulin sensitizer, you do not put anything in that can help overcome insulin resistance, unless they're being monitored by their doctor and their doctor is happy to look after them. We can only then work on the dietary side. So. Sorry? Yeah, it's mainly some of them that are so directly effective like that. So the chromium, some of the alpha lipoic acids, I would be careful in putting a combination like that in. I'll show you the one that I use in the clinic, but I wouldn't use it if they're on metformin or an insulin sensitizer. And just to show, this was an interesting study. It's an old one, but nobody else I've known has repeated it. So a woman with PCOS, in order to induce ovulation, the drug that she would be given would be called clomiphene. That's its generic name, trade name is Clomid. And that would be used to help her to ovulate, but if she gets pregnant on the clomiphene, she's still got the increased risk of miscarriage. And the drug itself also increases the risk of miscarriage. So she's got sort of an added effect from the PCOS plus the medication itself. But this was an interesting study where they first used just vitamin C on its own in women with an ovulatory cycles. And you'll see that in half the cycles, they started to ovulate just by adding in vitamin C. Now, there are groups of women who are classed as clomiphene resistant. They take the drug and it doesn't work for them. They're resistant to the response in terms of that ovulation. So what they did this time was they used vitamin C plus the medication. And it actually, by adding the vitamin C, it overcame the clomiphene resistance. So we can use, in a lot of the fertility work, they may be having IVF medication, and we would use vitamins and minerals alongside that. So sometimes a nutrient like this can help make that drug more effective. So really interesting to see that kind of research. And just to show you some of the work on IVF, so this is women with going through IVF treatment, significant increase in pregnancy rate with vitamin C. So anything that's going to help, and this could also be helping in natural conception as well, it's just that they can control it more going through IVF treatments. And in terms of older women as well. So when we're looking where the number of eggs produced in an IVF cycle may be less, and what we're working on with the antioxidants is improving the quality of those eggs, and either help that woman to conceive naturally or to improve the number of eggs that would be produced. As she gets older, she does not respond in terms of the IVF medication. So she doesn't produce as many eggs and the quality may not be so good. So anything that's going to improve that is really important. And this is quite staggering. This is vitamins E and C given to men who, with their partners, have gone through one failed ICSI treatment. So if they were having an ICSI treatment, you know that it's actually a male factor problem. Could be a problem on the woman's side as well, but there has to be a problem on the male side. And what they did was just gave the men vitamins E and C. And look at the difference in the pregnancy rate. 48.2% pregnancy rate on the 2 antioxidants versus 6.9% on the placebo after 2 months of treatment. And normally, again, for men, it's about 100 days. We talk about a 3-month turnaround in terms of the semen analysis. You wait 3 months to see the difference because of the maturation time of and the development of the sperm, what we call spermatogenesis. But you're seeing that after only 2 months of treatment. So really staggering difference. And this, obviously, they're seeing it in the IVF world, but we could be using this in terms of natural conception for that couple as well. And this is where the major research is going on in male fertility. It's on the antioxidant. This is a Cochrane review from last year, 34 studies. The men all undergoing assisted conception, so it would have been IVF or ICSI, taking varying antioxidant and varying amounts of antioxidants. But what the study showed was that antioxidant users in any combination are 5 times as likely to have a live birth compared to placebo. Staggering results, and yet the women and the couples don't often hear about this. It gets stuck in the academic literature. It's only them doing their research, and obviously you talking to them, could they maybe make changes like this that actually then helps them avoid needing assisted conception, because it's working on helping them conceive naturally. Yes?
Does this necessarily mean that we, or whoever needs to take antioxidant supplements, or can we do this via diet?
Well, you could. Are we talking about using antioxidant supplements? I would say yes.
Okay.
Only because, especially for fertility, we're under pressure of time usually, because the woman may be older. They may have been trying quite a while before they've even sought help for it. Yes, of course, the dietary side must be there as best as it can be. But in this factor of turning something around, I would absolutely add in the supplements for him and her at the same time, because there can be many deficiencies for different reasons, and you can test for them or you can just supplement them anyway. And vitamin C can increase sperm counts by up to 1/3 for the man. So the man would still do 500 milligrams twice a day, same as the woman does. He still does the fish oil that she does, and so we're trying to focus it for both of them. And really important, and a while back I was invited to give a talk to a support group at one of the IVF clinics, and they're very much now into this, what we call integrated medicine, by running the nutrition alongside the IVF treatment. And the embryologist there is a wonderful chap, and really has an understanding of this, but they've only just started including it. And one of the ladies in the audience, she said to him after, she said, "I'm really angry." She said, "Why didn't you tell me about all this information?" And he said, "Well, we're just getting to sort of grips with it." So, but it's important, and you can see it from their viewpoint, that somebody should have talked about this more, and they could have done more if they'd have known, and the couples want to do more. And I think for them, because IVF and assisted conception is very much, they feel like on a conveyor belt and everything is being done to them, that if we can give them tools for things that they can do for themselves, they feel like they've got some power back over this fertility problem, which they feel they don't have any control over. Coenzyme Q10 are really important in terms of energy production within the cells. It is important for glucose control. It's important for that woman with polycystic ovary syndrome. It's been used in terms of diabetic patients, and as you know, it also reduces high blood pressure as well. But it's actually also important for the man, because the sperm has got a head and a tail, and then it's got this mid piece, which is basically like the engine. And that's what's moving the sperm forward, and that's where the coenzyme, in terms of the mitochondrial action, is really important for sperm motility. So again, if we know what's going on with the semen analysis, you can focus the supplements more directly for that particular couple, because you can see where the issues might be. So other useful nutrients for this woman with PCOS would be zinc, and we're looking at helping a body cope with stress. Alpha-lipoic acid in terms of its general health benefits, but definitely improving insulin sensitivity. We're looking at the B vitamins on the stress effect, and also green tea extract. Anything that's going to help her lose that weight, which then can change the ovarian function fairly quickly. Yeah, sorry.
Does green tea not have caffeine in it?
Not the extract. No, so if it's in an extract form, there's no caffeine in there.
What type of form is the extract? Is it powder or?
Well, what I would do is I use a combination altogether, and it is done as a powder. It is a powder, but I'll show you it. The one thing that come out from the research is this problem of metformin causing actually a deficiency in B12. And if somebody, and this is whether it's a woman with PCOS or it's somebody you know that's on diabetic medication, if they've been on metformin for longer than 6 months, they should go and get a blood test for vitamin B12 deficiency. Really important, because it's something that's not mentioned over here at all, and I don't think it's picked up enough, and the women aren't told actually go and get a blood test for this and have it checked, and it should be pointed out to them, because many of them could have been on it a long time.
Is that because of methylation?
Yes.
Would it be benign as well?
Sorry?
Would it be benign as well?
Yes, and we would probably obviously put a combination of nutrients in there as well, but it depends whether they need it as an injection to overcome that deficiency in the situation if it's very severe. Vitamin D I've included in this as well, and the interesting research, and I know you know all the research in terms of osteoporosis, we're talking about cardiovascular health, we're also talking about cancer, especially breast cancer, but we're also looking at it now in terms of diabetes, but in this situation also with polycystic ovary syndrome as well. So low levels and deficiency of vitamin D associated with insulin resistance and obesity in women with PCOS. And those with the highest levels of levels of vitamin D, 72% less likely to develop type 2 diabetes. So it's one of those ones where, again, I think they should have a blood test. And in fact, I think all women should now have a blood test for vitamin D, because the levels are so low. We've got issues with deficiencies in this country. The government have now said that all pregnant women and children under the age of 5 should be taking 400 IUs of vitamin D a day. It's a government recommendation that's supposed to be trickling out through the GPs, because we've got a resurgence of rickets. And if a woman is deficient in vitamin D in pregnancy, she will give birth to a vitamin D deficient child. So it's critical, but we now know that it's important in issues before pregnancy as well. It is an immune modulator, and we're back to this effect of the immune system and the ability for that woman to get pregnant and stay pregnant. It's well known that deficiencies of vitamin D are connected to autoimmune problems, and they're now looking at it, of course, in terms of rheumatoid arthritis, but there's now suggestions of looking at it for people with MS, and then whether, if levels were corrected soon enough, could they slow down the progression of the problem. And it helps decrease this Th1, this autoimmune response. So again, it's important for any woman finding it difficult to get pregnant or having recurrent miscarriages. And obviously there are other reasons for miscarriages, and I've covered them all, like luteal phase defect and things like that in terms of the getting pregnant faster book, but we also have to think of immune problems as well as infections, as well as hormone imbalances as well, and of course the sperm side of it. Vitamin D promotes the suppressor Th2 cells that helps her body maintain a pregnancy, and we know that if they make mice deficient in vitamin D, it makes them infertile. It is a bigger issue for women, I think, because of the recommendations to stay out the sun. I think women have taken that on board quite strongly, but if you look at most women's moisturisers and cosmetics, there are inbuilt sun protection factors in there. So they may think actually they're going out in the sun, but they're not. And we routinely check it in the clinic. The gynecologist I work with has been doing it too, and he said he's staggered. 98% of the women he sees are deficient. There are some coming back where the lab can't detect any. And of course, you know, it depends on the country people live in, the colour of skin. There will be other issues as well, but it is staggering across the board. And yet it's such a simple test, and either somebody's deficient or they're not, and then we correct it. But it's one of those we have to think of for polycystic ovary syndrome, but also for fertility in general, and also miscarriage too. And for sperm. So this is not just, again, on the woman's side. We have to think about this in terms of vitamin D levels. If they're low, significantly associated with poor sperm motility, progressive motility, and there will be higher levels of abnormal sperm. So they're looking at vitamin D deficiencies across the board. Male and female fertility is just as important. Australia now recording vitamin D deficiencies in 1 out of 4 people, and more than 50% of adults in the UK has insufficient vitamin D levels. So this is becoming a bit of a crisis, and they realise that the the messages have been too strong in terms of stay out the sun. There has to be this balance of some exposure. We do not have many food sources. Food sources would be oily fish, egg yolks, fortified cereals, but the main source for the body is through the exposure through the skin. It is not necessarily through food sources. And as you know, cholesterol-like substances, substance produced from exposure through sunlight, we measure in a simple blood test, and as you know, there's a number of companies that have them, and either they can do it in a lab or there's finger prick tests. It's much easier to do it nowadays, and it's fairly inexpensive. It is, though, difficult even now, and we have women with established osteoporosis and their doctor still won't test vitamin D. So they're having to do it privately. I think it rates quite expensive on the NHS. They're not doing it even for a well-known connection with bone health, so we're less likely to get it done for fertility. They're having to pay for it privately.
Is it possible to overdose on vitamin D?
Yes, is it possible to overdose on vitamin D? I think it is, and I haven't included the slide because it wasn't the subject tonight, but there's some really interesting research on allergies and IgE allergic response, that there's a level of vitamin D. If you think of vitamin D is an immune modulator, so it balances the immune system, and there's a level whereby if it's too low, it increases the allergic response. If the vitamin D level is too high, it increases the allergic response. And we have to think about something as being in the correct range, and it's not then more of it is even better. There will come a point where it's flipping it the other way as well. It has to be, as with nature, it's always a question of getting the right balance. And I think then it's better to have a blood test, see what the level is, correct the deficiency, retest it 3 months' time, and then once you've got it at that level, it will be maintained by a multivitamin and mineral. If the level is D3 in the multi. Unfortunately, and we use practitioner supplement companies, some of them have quietly changed in the multivitamins. If you have a look, I won't mention any names because we're recording this, but they've changed D3 to D2 and not told us. And you'll see there, D3, 87% more effective in raising and maintaining a vitamin D level. So if somebody's deficient, we would add in a separate vitamin D on top of their multi for 3 months. Retest it again. Once that level is corrected, we're maintaining it with a multivitamin and mineral. And I agree, I think there are levels where people are taking too much, and I think it's much more important to test, supplement, retest, and then maintain it and do it that way. Siberian ginseng would be the herb of choice for the adrenal glands. It's classed as an adaptogenic herb, very much a balancing effect, like a tonic to the adrenal side. And we're, of course, working on changing her blood glucose levels by making her, by the food that she's eating, making her more insulin sensitive, increasing sex hormone binding globulin so it binds excess testosterone, and at the same time working on the adrenal side with the magnesium, the B vitamins, the Siberian ginseng, so she is not producing excess androgens from the adrenal glands. And it's trying to do, and it's possible to do all of this at the same time, and it's much faster that way. And I have put up here the amino acids. I find them very useful. Some of them are important in terms of counteracting high levels of cortisol. Some of them become, like arginine and glutamine, essential when under stress. And of course there's ones like tyrosine in terms of appetite control, and N-acetylcysteine in terms of sensitivity to insulin. So I think for me the amino acids are useful for a woman with polycystic ovary syndrome. And they could do all of these separately, and all the amounts I've put in the polycystic ovary syndrome book, but I've put 2 combinations together. Oh sorry, first of all, before that, there is a protocol for fertility, and this is the same for whatever reason the woman is not getting pregnant. And there is a man's version as well. So there's a fertility support for women, and these are different from an antenatal. For me, an antenatal, the levels aren't high enough, the combination isn't right. It's fine once they're pregnant, and then we switch it over. When they get to the 12 weeks of pregnancy and we know the pregnancy is secure, then that fertility one switches to an antenatal. But until that 12 weeks, we want to make sure that that pregnancy is secure, the placenta's taken over, because that 12 weeks is the highest risk of miscarriage. So there's a fertility support for women and also one for men, which contains certain extra amino acids for sperm health. She and he would take vitamin C, and they both do omega-3 fatty acids. And that would be the protocol until she gets pregnant, and then into the 12 weeks of pregnancy, and then the fertility one changes to an antenatal. Now, for the polycystic ovary side, she has to do a bit more. So if her goal is also pregnancy, so she may be running that alongside in terms of addressing the PCOS because she wants to get pregnant. Then at the same time, we address the insulin sensitivity and all of the other aspects at the same time. So I would put in the Nutri Support, and that's the one that's got the chromium, the magnesium, the Siberian ginseng, all of that combination for her in terms of control of blood glucose and the adrenal side, and it's got the green tea extract in there as well, and then the amino acids. So if a woman has got polycystic ovary syndrome and fertility is not on the radar at all, then she would just do those two with vitamin C and fish oil. But if her goal is also to get pregnant, then the fertility one goes in at the same time, and it's done deliberately, because otherwise she's doing the polycystic ovary side for 3 months, and then we're adding in the fertility one for another 3 months in order to get the levels right and the folic acid and everything else ready for pregnancy. But time may be an issue for her. So we actually double it up and do the fertility one at the same time as this, which is more unusual. I wouldn't usually make that combination, but I do in the situation for polycystic ovary syndrome because of the issues of time pressure. And it means then at the end of the 3 months, she's ready to get pregnant. And we've just moved it down and shortened the time for her. And she's just taking the fertility one at the same time in order to make it more effective, faster, and the time is shortened for her in terms of only 3 months rather than 6 months or so. Yeah? Yes?